Good morning and thank you organizers for inviting me again. This is the study of a new molecule, Taletrectinib, in patients with TKI naive or crizotinib pre-treated ROS1 positive non-small cell lung cancer. ROS1 we know is an oncogene on chromosome 6 and the rearrangements are seen in 22 different malignancies. Lung cancer, only 1 to 2% of patients have ROS1 rearrangement, typically seen in patients with lung cancer who are young, never or light smokers, and adenocarcinoma subtypes. It leads to, the ROS1 rearrangement leads to fusion portion of ROS1, including its tyrosine kinase domain, to several different partner proteins, and this constitutively activated proteins then function as oncogenic drivers. It is phylogenetically related to ALK, that is why most of the ALK TKIs work against the ROS1 positive patients as well. Crizotinib, we know it binds with high affinity both to ALK and ROS, and it inhibits ROS1 signaling, cell vitality in vitro. That is why it was the logical first choice, and we just had a discussion about various aspects of crizotinib, and it is one of the important choices for first-line ROS positive lung cancer, but it has a low activity in CNS. Actually, CNS is often the first and probably the only site of progression in ROS positive lung cancer in almost 50% of patients. That is why the search for a better treatment with a better CNS activity was ongoing. Then came this molecule, Taletrectinib, which is a next generation potent CNS penetrant selective ROS1 tyrosine kinase inhibitors. It's a TRUST study, which is a multi-center open label single arm phase 2 study, small study, just about 100 odd patients, is only Chinese patients. NSCLC patients who are TKI naive or previously treated with crizotinib. Chinese and TRUST sounds a little oxymoronic, nevertheless. Locally advanced metastatic lung cancers, patients who are above 18 years of age, good performance status, and ROS1 positive patients. The design is simple. The first part was a lead-in dose titration of 333, 400 and 600 milligrams, and then in the phase 2, part 2, Taletrectinib was given as 600 milligrams to both cohorts, either TKI naive, which was 16 number, and pre-treated with crizotinib, 14 number. And then the primary endpoint was overall response rate, and the secondary endpoint was duration of response, progression-free, intracranial duration of response, and overall survival. Remember, this was presented only as an abstract. The full studies, the full publication is yet to come, and there is a bigger study also being planned. Demography-wise, nothing very different. Most of what we already know, that it was common in adenocarcinomas, which is seen in majority of the patients, and a small fraction of patients had adenosquamous carcinoma. About 20% of patients had brain mets in the overall study, most of them in the pre-treated group. The waterfall plot looks impressive. You see the overall response rate is 92.5%. Phenomenal response rates. Usually we don't get to see such response rates in our oncology solid tumor patients. The overall response rate is 92.5. If you add stable disease to it, it goes up to 95.5%. And the responses were usually seen in the first two assessments. That's very important because this is a drug used in advanced metastatic settings. So if you have an earlier response, it is likely to bring about better symptomatic improvement early in the course of treatment. And median duration of response and median progression-free survival were not reached yet. Of course, this is too early days, but nevertheless looks impressive. The intracranial efficacy was even better. The intracranial overall response rate was 91.7%, and if you add that to stable disease, it was 100%. 100% is a figure which we rarely use in any solid tumor cancer. But these patients had great responses intracranially. There was hardly any, nobody had any progression. And they've shown a case who had both measurable brain lesions and no prior ROS TKI treatment. There was a complete disappearance of target lesions, and the patient continued to remain in good remission. Even with patients who were crizotinib pre-treated, which is the standard treatment today, the overall response rate was 50%. These were patients who were pre-treated both with crizotinib, and some of them were treated with chemotherapy as well. And the disease control rate, which added stable disease to it, was 78.9. So almost 80% of patients did have either stabilization or some kind of response. So that again is phenomenal. These waterfall plots are really something which we don't get to see in most of our drugs. Safety-wise, not too many side effects: diarrhea, transaminitis, nausea, vomiting, dizziness, anemia, and decreased appetite. Most of these treatment emergent adverse events were of lesser grade. The grade 3 side effects were fewer, not more than 10% of patients had grade 3 side effects, and none of them had grade 4 side effects. The interesting thing to be noted is, in spite of having such an extensive, great CNS activity, there were hardly any CNS related side effects. So dizziness and a little bit of fatigue was the only so-called CNS related side effects. Majority of them had only some GI toxicity. Dose reduction was required in about 14.2% patients, and 5.3% patients had to discontinue the treatment because of side effects. So Taletrectinib has impressive overall response rate both in naive as well as crizotinib pre-treated patients. It has great efficacy in patients who have failed crizotinib. Even in the crizotinib resistant mutations like G232R solvent front mutations. Intracranial disease control rate is 100%, making it a very, very important drug for patients who have CNS metastasis or CNS disease at diagnosis. And it is very highly selectively ROS1 inhibitor. So the systemic side effects are very minimal and not very significant. They have started a global phase 2 study. So it will be very interesting to see how this drug behaves in a slightly more diverse population and of course in bigger numbers. Thank you.